What's up, Ninja Nerds? In this video today, we are going to be talking about mitral valve disease that includes mitral valve stenosis and mitral valve regurgitation. Before we get started, if you guys like this video, you benefit from it, it helps you, it makes sense, please support us by hitting that like button, commenting on the comment section, and most importantly, subscribing. Also, down in the description box, we have a link to our website where you guys can check out some awesome notes, some amazing illustrations to follow along with during this video. So go check those out. Without further ado, let's get right into it and start talking about mitral valve disease. So, basic definition of mitral valve disease, there's mitral valve stenosis. When we talk about mitral valve stenosis, what's the issue with this? Okay, basic terminology, not using too much words and verbiage, it's simple. Whenever you have someone who has mitral stenosis, the primary issue with these is that the valve, the mitral valve, so the mitral valve is the valve that's usually separating between the left atrium and the left ventricle, this valve. It's really fibrotic. It's really stenotic. It's very calcified. And when it's like that, it reduces or slows or affects the flow going from the left atrium into the left ventricle. So the big thing that I want you guys to remember in mitral stenosis, in patients who have mitral stenosis, the primary issue is you have a fibrotic or some type of calcified valve. And that calcified valve, the issue with that valve is it does not allow for a good flow from the left atrium to the left ventricle. This is hindered. In that process, we have to think about what causes this valve to become fibrotic and calcified, and then what's the problematic issue that occurs whenever you aren't able to get enough blood flow from the left atrium into the left ventricle. That's what we got to talk about, so we'll do that in a second. Before we do that though, we also should talk about mitral regurgitation and compare and contrast it. In mitral regurgitation, the problem is again the mitral valve, but you see these valves here? Their problem is they have a poor seal. They're not good at actually coming together, coapting together. So whenever the ventricles go through their particular cardiac cycle and contract and relax, you know whenever they contract, the left ventricle goes into a period of contraction, it should want to do what? So here's your left ventricle, here's your left atrium. You want to push blood from your left ventricle out into the aorta. That's the goal. You don't want blood to go back into the left atrium. So when the ventricles are going through systole, they actually push blood in this disease from the left ventricle back up into the left atrium. And so that's important to remember. So in this disease, mitral regurgitation, the issue is you have a poor seal between the actual mitral valve. And this causes a backflow. This will cause a backflow from the left ventricle to the left atrium. So the question that we have to ask ourselves is, what causes this poor sealed valve? And then what are the issues that we run into whenever there's a backflow of blood from the left ventricle into the left atrium? The last thing that we want to talk about is when are these problematic issues occurring? So mitral stenosis, mitral regurgitation, in their cardiac cycle, when would this problematic issue be occurring? Would it be occurring when the ventricles are relaxing and getting filled with blood during diastole? Or is it occurring during systole when they're contracting and ejecting blood out? So in this case, think about the problem. Mitral stenosis is problematic flow from left atrium to left ventricle. That means blood are going into the ventricles. So this issue would be a diastolic problem. So this issue that you would see in this disease is a problem that's occurring during diastole. Whereas in this situation, the left ventricle is supposed to be contracting and ejecting blood out through the aorta, but blood goes back into the left atrium. So this is occurring during systole. So that is another important differentiating factor for the basic definition. All right, my friends, we've covered the basic definition. We talked about what's the problem. We talked about what can lead to these issues, particularly the left atrium to left ventricle flow is slow during diastole, and during regurgitation, there's backflow from the left ventricle into the left atrium. The next thing we got to talk about is what causes this fibrosis and calcifications of the valve, and then what causes the poor seal that you see associated with these diseases. So first thing up, mitral stenosis. What causes this dang old mitral valve to be super fibrotic, sclerotic, calcified in some way? I'm glad you asked, because you know what the most common kind of condition that you'll see here? You know, there's a condition in which your body you have like a strep infection, streptococcus infections, like particularly group A streptococcus, beta hemolyticus type of bacteria. In those situations, you produce antibodies against the bacteria, but sometimes people produce antibodies not against the bacteria only, but they produce bacteria against tissues in their body. And some of those tissues tend to be the valves of the heart. This condition that you see is called rheumatic heart disease. So in rheumatic heart disease, you develop autoantibodies that cause attack and actually cause inflammation of these mitral valves. And that inflammation over time causes fibrous deposition on the valves. That causes them to become very stiff and not wanting to open and allow for blood to easily flow from the left atrium to the left ventricle. That's one cause. Now, interesting thing with rheumatic heart disease is that you see this not only with mitral valve stenosis, you may see this with mitral valve regurgitation, and you can also see this with aortic stenosis and aortic regurgitation. So sometimes you see this involving not just the mitral valve, but also the aortic valve. And it can cause both stenosis and sometimes regurgitation in the severe stages. All right, beautiful. So we have rheumatic heart disease as one of the particular causes for that sclerotic fibrotic valve. What's the second one? The second one is also really interesting. So, you know, in patients who are really, really old, so you have some elderly patients. In elderly patients, they have they just have lots of issues where they can cause lots of calcium deposition into particular vessels and other tissues. And so they get lots of calcium deposition. So lots of calcium that deposits into the actual cardiac valves, particularly the mitral valve. You know, another condition in patients who have end-stage renal disease, in these situations, they develop something called secondary hyperparathyroidism. You know, parathyroid hormone, what does it do? It increases your calcium levels in the blood. And if you increase calcium levels in the blood, you again can increase the deposition onto these valves. So if you cause lots of calcium to deposit onto these valves, you make them very stiff, you make them very less pliable, and they're not good at allowing for blood to move easily from the left atrium into the left ventricle because these valves just don't want to let it go that way. All right, so that's a particular reason, right? So it's some type of calcifications. And this calcifications that you can see in these patients are particularly in high risk in patients who are elderly or end-stage renal disease patients. Okay, one more particular cause to be thinking about. This one's not super common, but it can happen. You know, there's a condition called carcinoid syndrome. Particularly in carcinoid syndrome, you see this more likely to involve the tricuspid valve more than the mitral valve. However, it's possible. So you know carcinoid syndrome, generally there's a cancer. There's generally some type of tumor that forms usually within the gastrointestinal tract first. So usually what happens is you get some type of tumor within the gastrointestinal tract. And that tumor may spread to the liver, and then from the liver, it may go to the right heart, and from the right heart, it may spread into the lungs and cause some actual tumor to deposit within the lungs. Either way, what's the problem with either of these tumors, whether it be in the GI tract or in the lungs? The problem with these tumors is they release a lot of something called serotonin. So one of the things that they release is they release something called 5-hydroxytryptamine, lots of serotonin. And that serotonin loves to deposit, cause a fibrosis. It causes a fibrotic reaction on the mitral valve. And if it causes it to become fibrotic, it reduces the normal flow from the left atrium into the left ventricle because the valves don't want to open as well, and they don't want to allow for blood to flow easily in this direction. So that's another particular reason, carcinoid syndrome. And again, this is usually due to neoplastic cells that are releasing 5-hydroxytryptamine, and this is causing fibrosis. Okay, beautiful. So the three particular causes that I want you guys to remember for mitral stenosis is rheumatic heart disease, but just big thing to remember is you can see this in mitral valve disease and aortic valve disease. Second one is calcifications, and third one is carcinoid syndrome. But don't forget these two. Let's talk about mitral regurgitation now and come down here. All right, so mitral regurgitation. In this condition, again, we know that there's a poor seal. What is causing that poor seal? What's not leading to the valves nicely coapting together? Because when the ventricles contract, the pressure should rise in the ventricle enough that it's higher than the pressure in the atria, and the valve, its purpose, its literal function is to snap shut and prevent backflow into the left atrium. It's not doing that. Why? Well, you gotta think about the anatomy of the actual mitral valve, the apparatus itself. There's three primary components of it. There's actually four components of it. We'll talk about that fourth component over here, but there's the annulus ring, okay? So there's the annulus ring, which is this black ring right here. And then off of that actual ring is your leaflets. And then off of the leaflets, there's these little cords that are made up of collagen and other types of connective tissue called chordae tendineae. And then the chordae tendineae are connected to these little muscles that are extensions of the myocardium that hold on to the little chordae tendineae and pull them tight to keep the valve leaflets close to one another. Those are called the papillary muscles. So there's technically 4 components of the actual mitral valve apparatus. That is the annulus, the leaflets, the chordae tendineae, and the papillary muscles. If there's some disease process that is affecting one of those 4 structures, that can definitely lead to mitral regurgitation because it's going to cause a poor seal. We're affecting that valve apparatus. Let's talk about those things. Now, primary mitral regurgitation is usually going to be conditions that cause an effect of the leaflets, the chordae tendineae, or the papillary muscles usually. So what are some things that can actually cause destruction or issues with the leaflets? You know, there's one condition which you definitely don't want to forget. You know, there's these nasty like bacteria sometimes that can actually accumulate on the valve, and they can release nasty like types of destructive molecules and lead to the actual destruction of these valves. And if I erode these valves away, do you think that this is going to be easy? Now you have a little nub of a valve, and when these are supposed to come together during ventricular systole, is that going to be good at being able to block the flow up into the left atrium when the left ventricle contracts? No, because now I got a nub and I got a long valve leaflet. So that's one of the issues. What is that disease process where you cause destruction of the leaflet due to bacterial infections? This is called infective endocarditis. So anytime someone has infective endocarditis, this is a very severe cause and can lead to very destructive lesions of that valve and cause acute mitral regurgitation, which is disastrous sometimes. Another thing that damages the valves, now this is, remember I was talking about rheumatic heart disease, it's a weird one where it can cause both stenosis and regurgitation. Here's what happens. So when rheumatic heart disease, right, you can also destroy those leaflets. Now it's a weird way that it does it. If you kind of imagine here that we have these valves, let's imagine here we have the annulus. So here's our annulus for the rheumatic heart disease example. Here's our annulus right there, right? And then off of that annulus ring is your leaflets. And for the mitral, there's the anterior leaflet and then the posterior leaflet. Now, generally these should kind of come together nicely and coapt together, right? And generally block blood flow from going into the left atrium during ventricular systole. When you get a lot of inflammation and fibrosis of these valves, okay, what starts happening is, yes, you kind of really cause them to become stiff and narrow, and they don't allow you to easily open up the valves to push blood down. That's definitely one issue. This can be affected. But if these valves are super stiff and super not pliable and they just don't want to move because they're super fibrotic, when you push blood, it's supposed to cause this and this to coapt together. But if they're super stiff and not pliable and you try to push blood against these to snap them shut, they may not snap shut. Instead, they'll run through that little space that's still open because the valve leaflets just don't want to touch one another because they're so stiff and so non-pliable. When you hit them, they're supposed to close, but you hit them and they just kind of still stay open. So it creates a little orifice for blood to jet into the left atrium. And that can happen with rheumatic heart disease, particularly on the severe stages of them. So that's things that you definitely want to think about that involve the leaflets. There's another condition. It's generally believed to be like, familial or sporadic. And there's lots of deposition, like lots of actual kind of like what's called proliferation of parts of the actual leaflet. It makes it kind of like easy to bow and bend. And this is called mitral valve prolapse. So this is actually due to what's called myxomatous proliferation of what's called the zona spongiosa, which is kind of like this inner tissue inside of the valve leaflet. It becomes really, really floppy, and it becomes really easy to bow. And that creates an opportunity if it's bowing, like you actually are supposed to be like this and it's bowing, now you create a little space for the blood to actually regurgitate right back into the left atrium. And so that's one particular condition to think about, okay? Now, what about the chordae tendineae? What can cause some issues with these? So imagine that the chordae tendineae are not very good at their job. They're supposed to anchor those leaflets and pull the valve leaflets closer together. Now, if for some reason the chordae tendineae have some issue where they aren't able to pull down tautly on those leaflets and keep them close together, and they're loose for some reason, there's some issue with them, then now this could potentially hang. And that could allow for an opening for blood to regurgitate back in. What are diseases that could damage the chordae tendineae? You know, these are particularly connective tissue diseases. You know, you can see this in mitral valve prolapse, but these particular conditions that you want to be aware of is something called Marfan syndrome, or, you know what else? Ehlers-Danlos syndrome. And then sometimes there's another condition called osteogenesis imperfecta. But these are the big ones that I want you guys to think about. So there could be some type of connective tissue diseases that are causing weakening of these chordae tendineae. They're not as strong. They're not able to generate a nice tautness of that leaflet, and they don't give you a good seal. What else? Okay, not only could it be the problem with the leaflets, not only could it be a problem with the chordae tendineae, but there's something wrong with the papillary muscles, my friends. What could that be due to? You know, good old papillary muscles, sometimes in patients who develop really nasty myocardial infarctions. So you know, if someone develops a really nasty myocardial infarction, particularly these tend to affect more of like the posterior leaflet than anything. But if you get like a myocardial infarction, and the particular territories that you'd want to be worried about is if someone had like what's called a posterior MI, that could be one, or, because that usually affects the posterior leaflet, or if they have an inferior MI, those sometimes can also give you destruction of the papillary muscles that anchor the posterior leaflet. But either way, you get a myocardial infarction, and that causes some destruction of this portion right here. Okay, let's say you get some destruction of the papillary muscles that are in the posterior portion. You infarct these areas, the myocardium and the nearby papillary muscles. If they're infarcted, are they able to pull down on the chordae tendineae and keep them taut? No. If they're not pulling down on the chordae tendineae, can they keep the leaflets nice and coapted together properly? No. And so now it opens up an opportunity to blood flow to regurgitate right back into the left atrium. So again, in a patient who has an MI, this can cause the papillary muscles to potentially rupture. So an MI may cause papillary rupture. And this is a big thing to think about. You want to know why? There's two particular conditions that can cause acute mitral regurgitation, which is a hemodynamic emergency. It can be a cardiovascular emergency. Infective endocarditis is a really, really scary one. And a papillary rupture is another particular scary one. These can cause acute mitral regurg. Sometimes rheumatic heart disease, if you get a really bad acute attack, it can as well. But these other ones like mitral valve prolapse, some of these connective tissue diseases, they're rarely going to be leading into any kind of like acute mitral regurgitation. They're more likely going to be a chronic issue. Okay, the secondary mitral regurgitation. So this comes back to the annulus. So there's a disease process that's causing stretching. So you know, here's your annulus, right? This is one of the components. So this is your annulus ring. And this is one of the components of the valve apparatus. So the annulus ring, you know, it's really interesting because it obviously holds on to the leaflets. And then from the leaflets, you obviously have to remember that these are connected to the chordae tendineae. And then from the chordae tendineae, these are connected to your papillary muscles. So we know all of these things at this point. What happens is, imagine a patient has a disease process that stretches the annulus ring. And if you stretch the annulus ring, you pull the leaflets that are anchored to it farther away from one another. And if these are farther away from one another, you lose a good seal. You're not able to get in those valve flaps close together. That can create a regurgitation. What are conditions that cause the annulus ring to be stretched? Anything that causes the dilation of the left ventricle. So something that's causing dilation of the left ventricle. What could that be due to, my friends? So things that would cause annulus ring to stretch. So we'll say this is usually due to the annulus ring. And the problem is that we're increasing the stretch. This would be conditions that cause left ventricular dilation. So this is due to left ventricular dilation. Okay, what could that be due to? What are some things that cause left ventricular dilation? So first things first is if someone has aortic regurgitation, that can cause blood to actually get larger volumes inside of this actual left ventricle, and that can cause it to distend and get bigger to accommodate those volumes. So one particular reason could be aortic regurgitation. A second one is you develop what's called dilated cardiomyopathy. And there's many different reasons for this, but the actual ventricles become damaged and they undergo a remodeling process where they get thinner and the ventricles get larger to accommodate larger volumes. It could also be due to some type of systolic heart failure of some kind. In these situations, these are very common reasons for someone to have left ventricular dilation. And so think about that, because this is a secondary cause of their mitral regurg. And again, secondary causes of mitral regurg are unlikely to produce an acute type of mitral regurg. These are going to fall in the category of more of a chronic. There's one more type of mitral regurgitation that is secondary because it's not due to any of the leaflets, none of the chordae tendineae, none of the papillary muscles, not even the annulus ring. This one's an interesting one. You know, there's a condition called hypertrophic obstructive cardiomyopathy. And hypertrophic obstructive cardiomyopathy, their problem is that they have this very hypertrophic septum. And when blood is actually supposed to be squeezed and run through this area, it's very narrow and it creates something called the Venturi effect. And that yanks this anterior leaflet of the mitral valve towards that left ventricular outflow tract. It obstructs it. And so then you can't get blood out through that way. But it also, if you pull this valve leaflet this way, what are you doing? You're creating space between the posterior leaflet and the anterior leaflet. Guess where the blood can go? Right back into the left atrium. This is a very interesting type of mitral regurgitation. This is a mitral regurgitation that is secondary due to something called systolic anterior motion of the mitral valve. So remember, this is another type of thing that you can see, what's called hypertrophic obstructive cardiomyopathy. It's not due to a problem with the leaflet, not due to a problem with the chordae tendineae, not due to the problem with the papillary muscles. It's not due to stretching of the annulus ring. It's due to a weird type of yanking of that anterior leaflet of the mitral valve during systole in this condition. So we've covered the causes, we've covered the definition of mitral stenosis and mitral regurg. Let's now talk about why is this a problem to have little flow going from the left atrium to the left ventricle and mitral stenosis, and then let's talk about what's the problem with having backflow from the left ventricle into the left atrium and mitral regurgitation. All right, so let's talk a little bit about mitral stenosis, particularly the pathophysiology and how that leads to the clinical features, their physical exam findings. So, mitral stenosis. So let's say here we have a normal kind of like opening of the mitral valve, right? So here's the two leaflets of your mitral valve. You have like your posterior leaflet and your anterior leaflet. And then here's the opening or the orifice by which blood is supposed to move through. So imagine like if I had blood coming, it was coming this way, whoop, and then out that way. Right? Nice little orifice there. That's a normal type of mitral valve. So this would be kind of fitting within your normal type of mitral valve. And then one of the ways we look at this is we look at like what's called the mitral valve surface area, right? So we look at what's called the mitral valve surface area, which normally, you know, it's somewhere between like 4 to 6 centimeters squared. That's about how large the orifice should be. And a patient who starts to have something called mitral stenosis. Now look at the blood that you're trying to squeeze through that tiny little area there. That's going to be a very small orifice. And so the mitral valve surface area in this patient who has mitral stenosis, they're going to have a very narrow area. And what happens is their mitral valve surface area starts dropping below this point, particularly when it starts to become diseased. It's at least less than 2 centimeters squared. And that's enough to start really reducing the blood flow from the left atrium into the left ventricle. So you see the whole process here is that this valve becomes so fibrotic, so calcified, and stenotic in a way that it reduces a lot of flow because you're narrowing the space of the mitral valve orifice. Now, how does that look like? Here's what I want you to think. Imagine you have an issue here where in this patient you have less blood that's able to get from the left atrium into the left ventricle. Right? So if that's the case, you're not filling the left ventricle appropriately with the volume that you want to during diastole, when the ventricles are supposed to be getting their blood. So if that's the case, this causes a low left ventricular in diastolic volume, right? The amount of volume that's in the left ventricle when it's relaxing before it actually pumps blood out. If that's the case, then that's called what? The volume of blood is in the heart that potentially can affect stroke volume. That's called preload. So there's a reduction in the preload. And if you drop your preload, you drop your stroke volume. And if you drop your stroke volume, you drop your cardiac output. What's the issue with this? This can cause forward heart failure problems. So if you get less blood that's filling into the actual left ventricle, you're going to potentially drop the amount of blood that you want to go out into the systemic circulation. And that's problematic because some of the ways that this could potentially present is this may present in a patient who may have something like hypotension, right? And if they're hypotensive and they're not able to perfuse particular organs, they may have like cool and clammy types of extremities, right? And that may be one particular sign. And they also may have potentially, if you're not able to get enough blood flow out of the actual heart, that also could lead to other particular manifestations, many, many different things. But these are things that we would want to think about, right? So this is a very nasty kind of situation. And this may present similar to kind of like a problem of a heart failure type of presentation. We're not able to get blood out of the heart because, actually not a problem getting blood out of the heart, we just don't have enough volume that's coming into the left ventricle because of this stenotic valve, so I'm not actually pumping enough volume out. The left ventricle is probably good enough and not having any issues. It's just I'm not getting the volume that I'm supposed to be getting from the left atrium. So that becomes an issue potentially. All right, what's the other issue that kind of goes along with this forward heart failure? So they may present with some hypotension. They may have some cool, clammy types of extremities due to this reduction in diastolic volume. But the other issue here is, think about this. If the left ventricle is not getting a lot of blood filled into it, right? So there's supposed to be blood coming from the left atrium into the left ventricle. It's supposed to go this way. Now, if it's not able to do this process, blood will start accumulating in the left atrium, right? So blood will start accumulating into the left atrium. So there'll be a high blood volume, and whenever the left atrium has a lot of volume and it can't actually expand or distend to accommodate that volume, the pressure in the left atrium will also start to go up. So there'll be a high blood volume and there'll also be a high pressure in the left atrium. The problem with that is that if there's all of this volume that's accumulating within the left atrium, what it's going to do is it's going to start causing a backflow. And when it starts backflowing, it backflows into the nearest vessels. And this is your pulmonary vessels, particularly the pulmonary veins. And it'll backflow into the pulmonary veins and then eventually into the pulmonary capillaries. And when it does that, it actually starts third spacing into the tissue layers between the actual alveoli and the pulmonary capillaries. And this can lead to pulmonary edema. So the clinical presentation of this is they may have pulmonary edema. And this may present with things like dyspnea that may be on exertion. So whenever they're having some shortness of breath walking because they're not getting enough oxygenation across the lungs, they may have something called paroxysmal nocturnal dyspnea, where they get short of breath when they're laying down flat because their actual hypoxia can worsen. Or they may have something like orthopnea, where their difficulty breathing can occur when they're laying flat. So a lot of these things could be potential clinical features here. So these are something else to remember for these patients. You know what else? Because this volume and pressure is so high, it can cause a lot of backflow. Enough that it can congest some blood vessels in the lungs, to the point where the pressure in those blood vessels increase and actually cause them to rupture. If they rupture because they're holding on to too much volume, that can cause blood to actually enter into the airway and us to cough that up. What's that called? Hemoptysis. So this can lead to hemoptysis. So these are also particular findings that you can see in these patients from a lot of pulmonary venous congestion. So because of the problem with getting blood into the left ventricle, we drop their stroke volume because we drop their preload. That can cause them to maybe have some hypotension, some cool, clammy, poor perfused extremities. If they're not getting blood from the left atrium into the left ventricle, it's accumulating there, the pressure is increasing, it's going to backflow into the pulmonary venous circulation and cause pulmonary edema, cause some congestion of some of the blood vessels in the lungs to the point where they may rupture and cause hemoptysis. Whew. What else can potentially happen? They can develop right heart failure, particular symptoms. Why? Let's come down and talk about that. You're causing some issues here where, again, the problem was that you weren't able to get blood from the left atrium into the left ventricle, right? And so the problematic issue here is that the blood accumulates, the blood volume accumulates, the blood pressure accumulates with inside of the left atrium, and it causes backflow. And it backflows into your pulmonary veins. Now here's the thing. When it backflows into the pulmonary veins, it backflows into the pulmonary capillaries and into the pulmonary arteries. And so then the blood pressure in the pulmonary arteries will start to go up. Imagine the pressure here in these pulmonary vessels being higher. So now imagine I'm going to put here, their pulmonary artery pressures are higher because of this backflow from the pulmonary venous circulation, because of a backflow from the left atrium, because that valve isn't letting blood get through. If the pulmonary artery pressure is higher, that means that this poor old right ventricle, which is pumping blood into the pulmonary arteries, is going to have to work harder. It's going to have to do some steroids and get all kinds of jacked up to be able to push blood out of the right ventricle into that high pulmonary artery system. So because, again, you get a backflow into the pulmonary veins, that increases the pulmonary artery pressure, and that increases the right ventricular strain. And so now the right ventricle has to start working harder to actually push against this high pressure. So what does it do? Guess what? The right ventricle gets ready to go get steroided up. And so it undergoes something called right ventricular hypertrophy. So when it actually causes this strain, what's really happening is it's causing right ventricular hypertrophy to thicken up, to push blood against that. Over time, though, this can lead to failure. Right? Because now if you're causing this ventricle to have to work harder, you're narrowing this lumen, you're not able to fill the right ventricle pop properly. And if you can't get blood into this right ventricle as well, because now this sucker is huge, then blood's going to start backing up into your superior vena cava and inferior vena cava. And so because of that, you may start getting failure symptoms, and it'll start actually backing up into the superior vena cava and inferior vena cava. So if it backs up into the superior vena cava, what could be some particular issues with that? Well, it'll back up into your jugular veins and cause those puppies to get all puffed up. And so it may cause something like jugular venous distension. If it backs up into the IVC, it may cause some swelling or accumulation of fluid around the liver and around the spleen, hepatosplenomegaly, may accumulate in the peritoneal cavity, ascites, may third space into the tissues of the lower extremities, pedal edema. So these may be findings. You may see something called hepatosplenomegaly. You may see something called ascites, and you may see something called pedal edema. And the whole purpose to understand this is that it was left-sided heart failure that led to right-sided heart failure. And what caused the left-sided heart failure? That dang old stenotic mitral valve not letting blood get into the left ventricle, and then it's just going to back up. Okay? Simple. All right, so we're going to talk about left atrial dilation, but again, make sure that you understand that the problems was you have forward heart failure, you have problems going into the left ventricle, blood flow getting into the left ventricle, so we're not getting enough out. That's causing that forward heart failure. Also, the blood isn't getting from the left atrium into the left ventricle, so it's backflowing. It's causing the venous vessels in the pulmonary system to get congested, causing edema, potentially hemoptysis, and that congestion in the pulmonary circulation can cause the pulmonary artery pressures to go up so high, it can lead to right-sided heart failure. Now, here's the last thing to think about. We talked about because the blood flow going from the left atrium into the left ventricle is halted, right? It's reduced because of these stenotic valves. The blood volume and what else? The pressure inside of this left atrium increases. Whenever there's high volume, generally, whenever there's higher volume states inside of the left atrium, what it'll do in the left atrium, what the left atrium will try to do is it'll actually undergo a process called dilation to accommodate that volume. So it'll cause left atrial dilation. Now, here's the issue. The left atrium is a big son of a gun. Okay, so it's a big son of a gun. A couple different things can happen. It may cause compression symptoms. So compress on things nearby, And we'll talk about what are those things and what things that we should be thinking about. The other thing is it stretches the electrical circuit. So you know when you stretch out the left atrium, now you're having problems sending electrical activity, because you have your SA node, then you got your AV node, bundled branches. What happens is when you stretch out this left atrium, it creates an opportunity for electrical kind of like circuits to develop and generate increasing types of atrial arrhythmias. So then they're also at risk for a very significant atrial arrhythmia. You know what that's called? Atrial fibrillation. So now they're at risk for what's called atrial fibrillation. What's the problem with these two things? Well, compression-wise, there is the esophagus nearby. So if the esophagus, which is running right behind us, is getting compressed by that big old left atrium, it may cause dysphagia. So there may be dysphagia, and that is due to the esophageal compression, right? So this could be due to esophageal compression. The other thing is it may compress on other nearby structures. You know, there's a nerve right near this area. There's a nerve that kind of comes underneath the aorta, the recurrent laryngeal nerve. Sometimes it's big enough to actually compress onto that. And that may cause hoarseness of the patient's voice. So it may not only cause, so another thing is compression, it can cause dysphagia. And the other thing is if it causes something called hoarseness. And this may be due to the recurrent laryngeal nerve being compressed. Okay, so we got that idea down. The next thing is the AFib. What's the problem with AFib? Well, now here's the thing. You got this big old left atrium. You obviously can cause electrical alterations and increase the risk of AFib. Obviously, the worry with AFib is that you increase the risk of emboli. You increase the risk of emboli. You're not getting effective atrial contractions. And so blood can kind of stay within this area, and here, let's do it in black. It can cause clots to form, right? It can cause clots to form here in the left atrium, which is going to increase the risk of that popping off. And if that pops off and goes into the systemic circulation, it can go up into the brain and lead to an embolic stroke. That's one particular thing. The other thing is that, look at this. Is blood getting from the left atrium into the left ventricle because of the stenotic valve? No. So another particular issue here is not only do you have an increased risk of atrial fibrillation causing the emboli, but you know what else increases the emboli? Another problem with this is just the stasis of blood flow, due to the stenotic valve not letting blood go from the left atrium into the left ventricle, so more blood stays within the left atrium. That is another particular problem. So again, AFib, increased risk of emboli, so you can get strokes, splenic infarcts, renal infarcts, mesenteric ischemia, tons of complications. But these are the things to think about. So now that we've covered mitral stenosis, their clinical features, their physical exam findings, now what I want to do is I want to move on and talk about mitral regurgitation, its pathophys, its clinical findings, its physical exam findings. All right, so with mitral regurgitation, we got to think about, again, the issue is blood is going back from the left ventricle into the left atrium, right? And there's something that's not forming a good seal. So again, in this situation here, just to compare, here's our normal mitral valve. So this mitral valve, we got blood in this issue, this situation, we want blood to, again, naturally do what? Naturally, whenever the actual ventricles go into systole, these leaflets will come close together. And when they come close together, their job is to come close together enough that they don't allow for blood to go back into the left atrium. So this should be the normal situation. There should be no regurgitation of blood back into the left atrium. So this would be the normal scenario. Okay, so there should be no regurg, jet that's flying back into the left atrium. In someone who's got mitral regurgitation, they got this big old gaping hole here due to the valve leaflets not actually having a good connection or seal between one another. So when the left ventricle contracts and pushes blood that's supposed to go into the aorta, it'll just move through this area here and then jet back into the left atrium. So this would be a patient who has mitral regurgitation because they're having a jet going from the left ventricle into the left atrium during systole. So that's the problem, is we have a large kind of opening here. Now here's the thing. Here's what you want to think about. And a patient who has mitral regurgitation, they can develop it acutely. And again, when I talk about acutely, what were the two scenarios that I wanted you guys to remember? One was infective endocarditis, and the second one was an MI. So they have papillary muscle rupture. These were the two particular indications. Sometimes acute rheumatic heart disease, like rheumatic fever, you may also develop this acute type of mitral regurg. This is a very nasty condition. Here's why. In mitral regurgitation, imagine your left ventricle, right? It wants to contract, and its job is to push blood into the aorta, right? And then obviously onto your systemic circulation. Inadvertently, due to this valve issue, these suckers ain't working, blood will go back into the left atrium during systole. So it'll go in these two directions. So blood is supposed to go where? Left ventricle into the aorta. But let's say that, just to give a number, let's say 75% of that blood went out into the aorta, and let's say 25% of that blood went back into the left atrium, okay? That means that the amount of blood that you're getting out of the heart is reduced. So we can say that in this patient here, they have a reduction in their left ventricular stroke volume because some of the blood is being regurged back into the left atrium. If there's a reduction in their left ventricular stroke volume, there is a reduction in their left ventricular cardiac output, and this can lead to hypotension, to the point where it can actually be in a shock kind of state, to the point where they can actually be in what's called cardiogenic shock. So that's one very scary situation where they can be extremely hypotensive. Here's the other thing to think about. When the left ventricle pumps this blood back into the left atrium, now here's the issue that's going to happen. The blood, it's going to go back into the left atrium when the ventricles are in systole. But when the ventricles get ready to go into a relaxation phase and get blood back from the left atrium, this blood is just going to flood right back down. So all the blood that was actually pushed from the left ventricle into the mitral, into the left atrium, is just going to come right back down during diastole. So think about that. 25% of the blood that was supposed to go out into the aorta is going to come right back down into the left ventricle. And plus, on top of that, it's also going to get the blood that's supposed to be coming from the pulmonary veins as well. So it's going to get a lot of blood that's coming into that left ventricle. So the next particular issue here is that you end up what's called a left ventricular end-diastolic volume. They're going to fill these ventricles full because blood is continuing to just keep going back and forth between the left ventricle, left atrium, back to the left ventricle. It's just going to keep happening. So they're going to get volume overloaded inside of the ventricle. When that happens, imagine like this. Imagine it kind of looking like this. I think this is the best way to kind of think about it here. The blood is now going to keep kind of flowing down here because you're pushing it up and it's just flowing back down. Imagine all this blood just continues to keep accumulating inside of the left ventricle. And these valve flaps aren't really kind of being very helpful. And so blood's starting to push back into the left atrium because it's just getting overfilled. If it continues to keep getting overfilled, it's going to eventually start pushing this blood back into the pulmonary circulation. Because normally what your ventricles would do is they would say, oh man, there's too much volume, I have to dilate. In an acute situation, you don't have time to be able to dilate. And so what happens is that pressure starts increasing because you're not dilating to accommodate the volume. And so when there's this high left ventricular end-diastolic volume, it causes high left atrial pressures. And that causes a backflow into the pulmonary veins. And that will lead to pulmonic congestion, particularly in the form of severe pulmonary edema, to the point where they can be extremely hypoxic. They can have dyspnea on exertion, dyspnea at rest. They can have paroxysmal nocturnal dyspnea, orthopnea, so on and so forth. So these are two of the particular presentations that you can see in a patient with acute mitral regurgitation, is cardiogenic shock and very severe pulmonary edema. Don't forget that, okay? This is really, really important finding and a acute mitral regurgitation that you would see in a patient secondary to infective endocarditis or an acute MI. Okay, now let's take this scenario now where you say, okay, their left ventricular stroke volume is reducing. They're not getting as much volume out of the heart, right? That was one of the issues that we were running into because a lot of the blood is getting pushed back into the left atrium. Well, what are the ways that our heart tries to accommodate for that? I'll talk to you and let's explain that how. All right, so the primary issue here is the left ventricle is just filling and filling and filling and filling with blood. So it's getting super overloaded. Okay, so the left ventricular end diastolic volume is just very high. Now, in a patient who develops they have mitral regurgitation, they start having a lot of this fluid overload kind of state, volume overload state. What we do to accommodate for this is you will dilate the left ventricle. You'll undergo what's called, it's a very specific type of process. You know, there's two different types of hypertrophy. One type of hypertrophy is where you actually add sarcomeres. You know, you have sarcomeres, let's say here I have a muscle cell. And in this I have sarcomeres, okay? If I add the sarcomeres in a linear fashion, like in a series, it's gonna cause the muscle cell to get longer. And that's called eccentric hypertrophy. That'll cause the actual ventricular walls to be thin, but the ventricles to be dilated. In a patient who I take like a sarcomere, for example, though, like here's a muscle cell, and I take the sarcomeres, like these, and I add them in parallel to one another. Then it's going to cause them to become bigger and thicker. This is called concentric. So what happens in these patients is they actually develop eccentric hypertrophy. That's their problem. Their actual muscle cells get longer and cause their ventricles to get thinner, but their actual lumen, the cavity of the ventricle, to get larger to accommodate all that volume. So they dilate their left ventricle. Let's just write down this purpose here. This is called eccentric hypertrophy. Now, when it does this, think about what happens now as a result of this. And what that does is it allows a higher volume to be in the ventricles, right? So now, if we dilate it, we can allow all that volume to be accommodated to where it's not actually backing up as much into the left atrium. So it can kind of stay within the left ventricle. We're just increasing the size, the pocket of that actual left ventricle, so more blood can stay here and less of it backflows into the actual left atrium. Less of it backflows into the pulmonary circulation. And so because of that, if you allow more volume to be within the left ventricle, two things happen. Here's where it's really interesting. Our ventricles are very smart. If you have a higher left ventricular end diastolic volume now, because you've actually allowed for this dilation, you have a much higher preload. If you have a much higher preload, you'll produce a higher stroke volume. And if you have a higher stroke volume, you'll have a higher cardiac output. So now this ventricle is accumulating all of this blood, and it's like, guess what, baby? I'm ready to just plow blood out into the aorta. Because it's accommodated itself in such a way where it can hold on to more volume. And we know that Frank Starling's law says if you increase preload, you increase stretch and increase stroke volume and increase cardiac output. Now we're going to push more blood out into the circulation. And that's going to help to alleviate some of the hypotension. So this will help to reduce the hypotension in these chronic stages. The other thing is that if we dilate, if we have this high left ventricular end diastolic volume, but we don't allow the blood to backflow, what we do is we reduce the backflow now. Because of the dilation process, that'll lead to less pulmonary edema. And that can also lessen the actual symptoms that you see in these patients, right? So that's some of the big things to think about in this chronic mitral regurgitation patients. Is one of the big things is that they undergo this type of process here called eccentric hypertrophy, where they dilate to accommodate or allow for more volume into them. And if they allow for more volume into them, less of it backflows into the left atrium. And less of that causes less pulmonary edema. If we have higher volumes in the left ventricle and the contractility is still good, we have more preload, more stroke volume, and it's going to be very hyperdynamic. And we can actually reduce the severity of hypotension. That's the big things to think about. So sometimes in these patients who have chronic mitral regurgitation, they're sometimes asymptomatic. And they don't have a lot of symptoms. They may have worsening symptoms. Particularly, they may get a little bit more hypotensive during situations where you have to undergo like exertion. They may get a little bit more short of breath when they're exerting themselves. But other than that, they're relatively asymptomatic. It's when they have this state and they undergo some issue where their contractility drops and they aren't able to maintain a good cardiac output. And then they start going into a decompensated state. What could that look like? All right, so the problem now is we have a patient with chronic mitral regurgitation. Honestly, they might be very non-specific symptoms, really, sometimes relatively asymptomatic. They may have a little bit of issues with perfusing tissues, especially when they're exerting themselves, because then they're having to work harder and maintain these higher cardiac outputs and help to prevent, in these situations, they may develop fatigue, they may develop dyspnea on exertion, but relatively asymptomatic. It's when they actually go into this decompensated state. So what do I mean? The good thing about a patient in chronic mitral regurg is that they have a lot of preload and high stroke volumes. So they're hyperdynamic, right? It's when the ejection fraction or the contractility starts dropping. So when you get all of these ballooned up ventricles that are accumulating all of this blood, the problem arises when the contractility starts dropping. So if there is a reduction in the contractility, that's where you might see some issues. So if you have low contractility, that's decreasing, but you're still having good preload, there may be kind of an offsetting thing there. But it depends. If the contractility goes down, you drop your stroke volume. And if you drop your stroke volume, you drop your cardiac output. If you drop your cardiac output, you can potentially worsen their hypotension. And so this can cause, potentially, go into cardiogenic shock. It may cause non-specific symptoms if it's not as severe, such as fatigue and dyspnea on exertion, cool, clammy kind of extremities, or decreased, relatively not well perfused extremities. But this is something that can happen. So if they develop a reduction in contractility, in other words, they're progressing towards heart failure. So sometimes what happens is when you dilate these ventricles so much, they get thin, they get weak, and if their disease continues to progress, they maybe start developing heart failure to the point where their contractility drops and their output drops and they can become hypotensive. On top of that, if their contractility drops, the other issue here is that if you get less stroke volume out, right? So less stroke volume, less blood leaves the left ventricle. The problem now is that we have less blood leaving the left ventricle. What was one of the already primary problems in this disease? Well, combine that with them having high left ventricular end diastolic volumes, them already having a lot of blood within their left side of the heart. Now they've accommodated and dilated, but if their contractility drops and you're not able to get as much blood out of the heart now, you're accumulating even more blood on top of that. And so in this situation, what you start getting is that backflow again. And if that backflow occurs, that's going to lead to, again, that onset of pulmonary edema. So basically what this is showing you is that someone who has decompensated chronic mitral regurgitation, in other words, they're having progression of their heart, they're actually developing heart failure, this can lead to them kind of presenting like an acute mitral regurgitation patient. So they can actually go from a chronic and then convert into a decompensated stage, which looks like an acute mitral regurgitation. Now, that's the big things to think about. So we have a strong idea now about the pathophysiology about kind of acute and chronic, and then when someone decompensates, they kind of go back into the acute stage. The next thing to think about here is what are some other issues, particularly with that left ventricular dilation. You can actually have some interesting things that you'd want to remember. When this left ventricle dilates, it's really good at allowing for blood to enter into it rapidly. So whenever the ventricles actually go into their diastolic process, blood rapidly flows into them during diastole. And when blood rapidly flows into these ventricles, it produces a turbulent flow and it bounces off the ventricular walls. And that can produce a S3 heart sound. So that's one thing that you want to remember in these patients due to their rapid ventricular filling is they may have an S3 heart sound. Also, their left ventricle is huge. It's getting really big. And so imagine the left ventricle here, just like this, right? Imagine now I dilated. What am I doing? I'm displacing the left ventricle more laterally. So whenever you're supposed to feel what's called the PMI, the point of maximal intensity, it's usually near the apex. Now, their left ventricle is dilated, it's going to be displaced more laterally. And on top of that, they're so filled with blood, every time the left ventricle contracts, it's got a lot of preload, right? So it's going to be slanging and a banging, clanging and a banging. So you're going to get very intense thrusting quality that when you're palpating near the PMI, they have a very thrusting type of quality and it's laterally displaced. That's another big thing here. Because of the dilation it causes, lateral displacement of the PMI, the point of maximal intensity. And on top of that, when you do feel the point of maximal intensity, it has a very strong thrusting quality due to it being hyperdynamic. It's so filled with blood that its preload's high, and if its stroke volume's really high, it's going to keep pounding and pounding and producing that thrusting quality against the chest wall, which you'll feel when you palpate near that area. So these are big things to remember as well. All right, Ninjas, so we got down the mitral stenosis, mitral regurg, clinical features, the physical exam findings. We haven't talked about the murmurs yet. I want to get into that in the diagnosis section because it's super critical. And we've also covered the pathophysiology here. So now that we've really built our foundation on mitral stenosis, mitral regurg, let's now get in and talk about the diagnosis, starting with the murmurs, and then we'll get into some other tests like chest x-ray, EKG, but looking at the big one, which is echo. Let's do that now. All right, so when we talk about mitral stenosis, we're going to go over the diagnosis, right? We've really gone over this disease pretty well. What we need to now think about in this patient is their heart murmurs. This is obviously a very important point when we talk about valvular heart diseases. That's one of the classic things is you're listening to a patient and you're, oh, I hear a dang good murmur there. Something's going on. We should be able to identify that murmur and to potentially classify it into this category of mitral stenosis or mitral regurgitation. So in mitral stenosis, you got to go back. What did we say? The problem with this disease is there's a fibrotic, there's a sclerotic, there's a calcified valve that doesn't allow for good blood flow between the left atrium and the left ventricle during what phase? Ventricular diastole. So the problem is I'm having difficulty getting this blood from the left atrium down to the left ventricle during diastole. So S1 begins the onset of ventricular systole. So would it occur in between S1 and S2? Well, that begs the next question. What's S2? S2 is the onset of ventricular diastole. So would I hear that actual murmur between S1 and S2? So in other words, during ventricular systole? No. Would I hear it from S2 to S1, which is ventricular diastole? Yes. And when in diastole would I hear it? Well, the problem is getting blood flow right across that valve. So once diastole starts, the actual atria want to push blood down from the left atrium into the left ventricle. Here's the problem. If this valve is really, really stenotic and really fibrotic, whenever the actual blood flow tries to move across this valve, it may actually cause the valve to kind of like bow a little bit. And when it bows a little bit, it can kind of produce like this snapping type of sound, which is the snapping open or bowing of the actual fibrotic mitral valve. And so sometimes you may have this little like snapping sound. And this snapping sound is actually literally called the opening snap, and it occurs right after S2. Now, after that happens, after you snap it open a little bit, more blood is going to rush through this area during the early and mid phases of diastole. So there's 3 phases of ventricular diastole. There's early, there's mid, and there's late. Okay? And the early phase is when you try to rapidly fill the ventricles. In the mid, you're filling the ventricles a little bit, and during the late phase, the atria is supposed to contract and push down the remaining 10-20% of blood into the ventricles. So in the opening snap, we snap the valve open. We get a little acoustic sound there. Then as blood is rushing out, it's going to rush out quickly during the early phases. So more blood rushing across that valve, that stenotic valve, will produce the loudest sound. So it'll start off loud, and as it goes towards like the mid phase here, it'll get softer because less blood is going to be running through this as we go through the rapid filling in the early phase, and then less blood will be flowing through it through the middle phase of diastole. So we call this an opening snap with a diastolic decrescendo murmur in like a rumbling fashion. So what's the first thing that you have? First thing is you have a opening snap. Then you have a diastolic decrescendo murmur. And we commonly describe this sound as a rumble. Rumble in the jungle. Now, that's one of the things that can happen. There's another thing that can happen. Remember I told you, Early phase is when there's rapid filling. So you're gonna have rapid filling, that's why it's the loudest in the beginning. Then as you go to the middle, less filling. As you go to the late phase, that's when the atria is supposed to contract. When the atria contracts, it may produce a little accentuation here, a little pre-ventricular systolic accentuation. And we literally call this the pre-systolic accentuation. You may hear that a little bit right before you go into S1. Big thing to remember though, guess what? Mitral stenosis is at high risk of what disease? Atrial fibrillation. This pre-systolic accentuation is due to the atrial kick. In patients who have AFib, they do not have an atrial kick. So if they do not have an atrial kick, would they have a pre-systolic accentuation? No. So there would be no pre-systolic accentuation in these patients. So potentially, if you have someone with mitral stenosis and you hear a and then you hear their actual S1 sound, that could be they're having a opening snap with a diastolic decrescendo rumbling murmur with a pre-systolic accentuation. If they have AFib, they'll just have the opening snap with the diastolic decrescendo rumbling murmur without the pre-systolic accentuation. That's what I want you to remember. Now the next thing I want you to remember is, what's the best area to listen to this? The best area in general for mitral valve is usually the left, so position-wise, we like the left fifth intercostal space, the left fifth intercostal space, mid-clavicular line. So we say the left fifth intercostal space, mid-clavicular line. Now, that's one. We can even actually isolate this murmur even better if we put them on their side in what's called the left lateral decubitus position. So sometimes it's even better because we get the apex closer to the chest wall if they're in what's called the left lateral decubitus position. So these are things I want you guys to remember, okay? Listen in these areas, listening for the opening snap, the diastolic decrescendo murmur with the rumble, potentially pre-systolic accentuation. And again, it is a diastolic murmur that you need to remember. Okay, what else can we do for these patients? We can get an ECG. Is it going to help me? No. So should you guys really remember this? Not really. I wouldn't focus too much. We're going to hit quickly what you could see though. In this situation here, and a patient who may have, again, mitral stenosis, their left atrium may be enlarged. It may be dilated. If their left atrium is enlarged, they may have left atrial enlargement evident on their EKG. How do we determine that? Well, you look at lead 2, right? And then lead 2, you see a large M wave. So you see kind of like this bifid wave that you see in lead 2. Or you look in V1 and you see that they'll have a P wave, but it'll be a biphasic P wave in their upright portion of it. And then there's a downward portion of it, right? They'll have a very deep negative portion. So this portion will be much deeper in V1. So again, this is their P wave. And this is their P wave that you'll see in lead 2. They'll have a very bifid, large P wave. And in V1, they have a biphasic P wave with the actual terminal component deeper. Yes, that's one thing to remember. The other thing that you may have here is, again, patients with mitral stenosis are at very high risk for what condition? They're very high risk for atrial fibrillation. So you may see a patient with atrial fibrillation potentially present. The other thing with mitral stenosis is we cause their pulmonary artery pressures to be high. What does that do to the right ventricle? Jacks it up. When the right ventricle gets super thick, it can cause right ventricular hypertrophy. So the right ventricular hypertrophy would cause the R waves. So this would generally cause the R waves to be greater than the S waves in V1 to V3. Because in the R waves in that, the determination determines like the depolarization, particularly from the right side of the heart. So they actually may be larger R waves coming from V1 to V3 than you would actually see. Generally, the S waves should be a little bit larger and then the R waves, and particularly V1 to V3 in normal patients. But in these patients who have right ventricle hypertrophy, their R waves may be greater than their S waves, and that's what's generally abnormal. So these may be some particular findings. Again, non-specific though, right? Doesn't diagnose mitral stenosis. The murmur tells me something's odd. EKG may help you a little bit. Chest x-ray, is it going to do anything for me? Not necessarily, to be honest with you. What could it potentially tell me? Again, what is particularly one of the clinical features that you can see with mitral stenosis? You can see fluid backing up, blood backing up into the lungs, causing a lot of that pulmonary edema. So there may be potentially some pulmonary edema present when you get a chest x-ray. Now, another thing is that the left atrium get all kinds of big and dilated. So could you potentially see some left atrial enlargement? You may see some left atrial enlargement. There may be some left atrial enlargement that's visible on that portion. But you know what else is really interesting? So the left atrium, it's near the bronchus, the left bronchus. It can actually get big enough that it can splay or push the left mainstem bronchus superiorly. So you may see, and sometimes they love to ask this or put this in the actual question stem for your exams, is it lifts the left bronchus superiorly. So that potentially could be an additional finding. So if there is something off the chest x-ray, don't forget this one, because sometimes they'd like to add that one in there. All right, so the gold standard test, if you guys don't remember any of the diagnostic steps, you guys gotta remember this one, it's the echo. This is what's gonna tell us mitral stenosis, but it's also gonna tell us a lot more. Not only is it gonna diagnose mitral stenosis, it's gonna tell us the severity of mitral stenosis, which obviously is gonna determine our degree of treatment. How quickly are we gonna accelerate them to non-invasive versus invasive management? So it's very important to know the echo. So the echo is going to give us a lot of information. Some of the things that we really want to look at for these patients is we really want to look at these valves, right? So we want to take a look at these valves. You might be able to see that they're very thick and sclerotic and stenotic, but really what I want to know is some of the effects of that actual fibrotic and sclerotic valve. One of the things is that, again, lots of blood and pressure are accumulating, lots of volume and pressure are accumulating in the left atrium, so it has to dilate. So the left atrial diameter will increase. So that's one of the big things. The larger that left atrial diameter is, the worse that degree of stenosis. And also, if the left atrial diameter is really high, they may have very high left atrial pressures. And again, that's kind of a bad prognostic sign as well. The other thing to think about is that sometimes if they do have these large, like dilated atrium, they likely have an increased risk of atrial fibrillation. So also potentially look, oh, do they have any like left atrial like embolus or thrombus there? So again, another thing to look for is, do they have any left atrial thrombus present? Okay, that's some of the things that you definitely want to be looking for. The second thing, which is very, very important, is not just the left atrial diameter, but the mitral valve area. So in other words, the area, the kind of like the narrowing, the space, the orifice by which the actual blood is flowing from the left atrium to the left ventricle. The smaller that actual orifice is, the smaller the area, and that determines the degree of stenosis. So normally it's about 4 to 6. The smaller it gets, generally like less than 2 is diagnostic, but severe, like severe, is generally, we can start off by saying it can be kind of like moderate to severe by less than or equal to like 1.5 centimeters squared, but severe is less than 1 centimeter squared. So this may be like moderate to severe, and then this one is just full-blown severe. When you see these kinds of situations, that's going to tell you that that's going to be one of the big things. The smaller this is, the worse the actual stenosis is. And the smaller that is, the higher pressure that the left atrium is going to have to generate to push blood through that tiny little opening. So if the actual stenosis is worse, meaning that the mitral valve area is really small, the pressure which I have to exert to push blood across that area is going to be high. And so that's called the mean pressure gradient. So the mean pressure gradient, the higher it is, the worst case scenario. Mitral valve area, the lower it is, the worse the scenario. So generally we say whenever the number is getting greater than or equal to 10 millimeters of mercury, that's really high, and that's kind of indicative of a severe type of mitral stenosis. So these are things to be thinking about. Look at the large left atrium. That tells us we have high left atrial pressures. Look at the mitral valve area. The smaller it is, particularly getting towards 1 centimeter squared or less, really bad. And then the mean pressure gradient, the pressure that you're having to exert to push blood across that valve, the higher that is, particularly greater than or equal to 10, the worse the stenosis. All right, so let's now talk about mitral regurgitation. So when we're looking at mitral regurgitation, it's important to know the murmur. Okay, we have to know the murmur. So we have a patient with mitral regurgitation. The issue with this disease is that these actual mitral valve leaflets are not getting a good seal. Blood is backflowing from the left ventricle into the left atrium during what phase of the cardiac cycle? During ventricular systole. Ventricular systole is between S1 to S2. S2 to S1 is ventricular diastole. So it would occur between this phase. Now, when someone has this type of murmur, it's very interesting. When the blood backflows during the onset of systole, okay, the actual murmur continues throughout the entire process of systole, generally at about the same intensity throughout the entire process. So when we look at this, you'll see that they have a murmur that is throughout the entire process of systole at the same intensity. What is this called? We refer to this as a holosystolic murmur. So it's a murmur that is occurring during ventricular systole, and it is holo or pan, meaning it's throughout the entire process of systole with the same type of intensity. Now that is an important one to remember. What else is important about this murmur? You know what else is important about this murmur is obviously we should know different types of maneuvers that increase the intensity of the murmur or decrease the intensity of the murmurs. We'll have another video where we actually go over all the different heart murmurs and all the accentuation stuff. But basically, what you want to be thinking about in these patients is anything that really increases the venous return into the left side of the heart is going to increase the intensity of the murmur, right? So if you increase the venous return to the left side of the heart, that's going to increase the intensity of the murmur. How do you increase the venous return to the heart? Generally, it's going to be through processes like squatting or having them do a leg raise, right? Those would increase the venous return to the right side of the heart and then eventually increase whenever the right ventricle gets lots of blood, it'll pump that to this left atrium, right? That's one thing. The other thing is expiration. So whenever you expire, that actually causes the lungs to kind of get smaller and squeeze the pulmonary blood back into the left atrium. Whereas in inspiration, that's when you fill your right side of the heart. So in inspiration, you increase venous return to the right side of the heart. During expiration, you increase venous return to the left side of the heart. So these murmurs would actually increase with expiration, but they would also increase with any venous return mechanism like squatting and passive leg raises. The other thing is, if we have more blood in this actual left ventricle, when it contracts, it's going to push more blood across the actual mitral valve and into the left atrium. So we want something that's going to cause higher amounts of afterload. So if you also increase the patient's afterload, that will also cause them to have what kind of thing with their stroke volume? They'll have a decreased stroke volume. And because of that, they're going to have more volume of blood in their left ventricle, and that's going to also increase the intensity. If they have more blood in the left ventricle, when they contract, they're going to push tons of volume of blood back into the left atrium, and that's going to cause an intensification of the murmur. So these are big things to think about. Now, where would I hear this murmur? Again, it's important to remember that it's best heard at the left fifth intercostal space, mid-clavicular line, but it can definitely be heard a little bit better in the left lateral decubitus position. The other thing is when it's spraying blood backwards into the left atrium, it tends to kind of aim it towards that left atrium to where it can actually be sometimes heard in the axilla. So sometimes it can radiate to the level of the axilla. So these are things to be thinking about. So it's a holosystolic murmur. It is best heard at the left fifth intercostal space, mid-clavicular line, or left lateral decubitus, and it radiates into the axilla. These are big things. And anything that increases the venous return will increase the intensity of the murmur, and anything that increases the afterload will increase the intensity of the murmur. And anytime they go and have an expiration, it'll increase the intensity of the murmur. Mitral stenosis, a lot of this stuff would be said similar because, again, with mitral stenosis, you want more blood to go across that mitral valve. So if you have them expire, it'll increase the blood flow across the valve, increasing the diastolic rumble and potentially the opening snap. Or if you have them have an increase in venous return, so you have them squat or lift their legs, it'll increase the flow to the right side of the heart and then eventually to the left side. And that'll also increase the intensity of the murmur. So those are things to think about, my friends. Okay. Okay, now that we've done that, what about the EKG? Can the EKG help me? It's not really going to be super helpful, but I can actually go through it. What are some of the things to think about? Well, again, with these patients, their actual left atrium may or may not be dilated. And so there could be some signs of left atrial enlargement. And again, we already talked about what that would look like. We said we would look at lead 2 for the M wave, and we would look at V1 for the biphasic, but the deeper terminal portion. That's something that you could potentially see. Could they have atrial fibrillation? They may have atrial fibrillation. Again, if there's dilation of the left atrium, there's a high risk of atrial fibrillation. On top of that, if you have someone who has this high amounts of pulmonary artery pressure because you're pushing blood back into their left side of the heart and into the pulmonary veins, it could increase their pulmonary artery pressure and cause their right side of the heart to have to work harder. So there may also potentially be right ventricular hypertrophy. But again, a lot of these things aren't super diagnostic. So it's not something to super remember and go crazy about. Okay. What I do want you guys to think about is the chest x-ray. Is there anything that could help me with the chest x-ray? Again, probably not anything that's going to be super significant. I may see some signs of pulmonary edema. I may see some mild signs of pulmonary edema, especially in acute especially in acute mitral regurgitation. In acute mitral regurgitation, I may see intense amounts of pulmonary edema. So these are definitely things to think about. Could I see some left atrial enlargement? I definitely potentially could see some left atrial enlargement as well. But I'd say that really the main finding is just the pulmonary edema. You're not really going to see too much else. You may see some left atrial enlargement, but again, it's a potential plus or minus kind of situation. All right, so obviously the most important test is the echo, right? We can think about the EKG and the chest x-ray, but they're not going to be super helpful. They're not going to tell me, oh yeah, it is. That's mitral regurg, baby. No, you hear a murmur. You think it's holosystolic. You definitely hear it at the left lateral decubitus position or the left fifth intercostal space. Mid-clavicular line, you hear that thing blowing and radiating back into the axilla. So you definitely think, ooh, this could be mitral regurg. Get the echo to confirm, but also get the echo to tell me how bad and how severe it is so I can determine what my management is. So what I'm looking for is I'm obviously looking for a regurgitation jet. I'm looking for blood to just jet back from the left ventricle into the left atrium. So that's one thing. So I know I got a regurgitation jet, but what I want to know is how bad is that jet? Because that's going to determine if it's mild, if it's moderate, if it's severe. And the ones that are bad is the ones that I got to be thinking about. So I got to know the severe stuff. So the regurgitation fraction is how much of that actual regurgitation jet backed up into the left atrium. And generally, whenever that number is greater than or equal to 50%, it's pretty bad. It's pretty bad, and they may need some more aggressive management, particularly maybe some replacement. Regurgitation jet width. So what we want to know is the worst case scenario. So what is the actual width of this jet? And how bad is that? And generally, whenever it's greater than or equal to 0.7 centimeters, that's pretty bad. And that's going to be someone, again, who might need a replacement. Left ventricular insystolic diameter. All this tells me is how dilated my left ventricle is. Remember I told you that in these patients, they have very high left ventricular end diastolic volume. They're pushing blood into the left atrium, is going right back down. And so their ventricles are big and large and dilated. The larger and dilated they are, the worst case scenario it could be because it's going to progress into heart failure. So in these patients, when they're in systolic diameter, the amount of blood that's in their ventricles right before they go into systole, how big are they? They're whopping big. And when it gets greater than or equal to 40 millimeters, this is pretty bad. The last situation here is these patients with mitral regurgitation, they have hyperdynamic hearts. So they're having very high end diastolic volumes. So they're having very high stroke volumes. And so they're probably having very high ejection fractions. Honestly, their ejection fractions are probably normally greater than 60%. But the problem is whenever they start getting into that decompensated stage of their actual chronic mitral regurgitation, where their ventricles contractility is starting to go downhill, that is a recipe for disaster, because then they're not able to maintain that good cardiac output. Blood in the ventricles stay there, they accumulate. And again, what's going to happen? It's going to back up into the lungs, cause pulmonary edema. If the contractility drops, I'm not able to get as much blood out of the heart, and so I become hypotensive. And so in these situations, when the ejection fraction, believe it or not, is anything less than 60%. Particularly, we kind of say, around 30 to 60%. is actually pretty bad. You know, for someone who thinks, oh, EF is 60%, that's not too bad. But if it's like less than 60%, generally we say 30 to 60%, that's pretty bad. Regardless of them being asymptomatic or symptomatic, that is a significant type of mitral regurgitation. So that's one of the big things to be thinking about here. So we've gone through, we've talked about mitral regurgitation, we've diagnosed it, we determined its severity. We have a good idea now of how we're going to approach these patients. So let's talk about their approach and how we treat them. All right, so let's talk about the treatment of mitral valve diseases, right? So again, when we're talking about mitral valve disease, we're talking about stenosis, we're talking about regurgitation. A lot of them can have some of the similar symptoms, right? We said a lot of them, particularly in these cases, they may have symptoms of heart failure, right? There may be some forward heart failure that's going on in mitral stenosis. There may be some backflow that's going on, and particularly with both of these situations, that's causing pulmonary edema, that's increasing their pulmonary artery pressures, and it's leading to right side heart failure. So they can have biventricular failure. In those situations, you want to treat their underlying heart failure. And sometimes the symptomatic things that we're utilizing is trying to fluid restrict them. So we might try to restrict excessive amounts of fluid and sodium restriction to prevent a lot of the symptomatic problems of what? Pulmonary edema, lower extremity edema, ascites, so more of that right side heart failure particular symptoms, but again, left side heart failure with the pulmonary edema. We may need diuretics for these patients as well. And then obviously with patients who have heart failure, what some of the baseline foundations for these patients is treating them with ACE inhibitors and beta blockers, if particularly tolerated. And sometimes you can even add on something like an aldosterone antagonist, like aldactone or eplerenone, things of that nature. Okay, so these are basically how we try to treat these patients' heart failure. Now, big thing, fluid, sodium restriction, and diuretics for the symptomatic processes. ACE inhibitors, beta blockers, and aldosterone antagonists have been shown to be able to potentially reduce some of the mortality and remodeling that occur in heart failure. These are some of the things that you're trying to do because of the patient having mitral stenosis or mitral regurgitation. And again, particularly this could be mitral stenosis and it'd be more chronic mitral regurgitation. Atrial fibrillation, both of these patients can have atrial fibrillation. What is the concern with atrial fibrillation? In patients who have atrial fibrillation, they're at high risk of emboli. So because they're at high risk of throwing an embolus, we need to consider anticoagulation for these patients. And usually patients who have some type of mitral valve disease, we actually consider them to be more of a valvular type of AFib. And these patients, particularly with valvular AFib, warfarin tends to be the actual preferred anticoagulant to reduce the risk of throwing embolic strokes. The other thing is patients who have atrial fibrillation, sometimes they can have issues with their rates, and sometimes they can have rapid AFib, and they can go into these really high rates. And so sometimes they may also need additional rate and rhythm control. And this may involve multiple medications that we talked about within our atrial fibrillation lecture. But I think the big thing to take into consideration is they may need anticoagulation, high likelihood of anticoagulation, especially, which one more commonly? So which one would this be a little bit more intense for? Mitral stenosis more commonly than mitral regurgitations. That's a big one to think about. Okay, so we'll treat their heart failure if they have that. We'll treat atrial fibrillation with anticoagulation, particularly warfarin, more likely mitral stenosis than mitral regurgitation. The other thing that we have to be thinking about these in patients is mitral stenosis. What are some of the other things that we need to think about? So mitral stenosis, they will potentially have some forward heart failure. They have some backflow into the lungs with pulmonary edema, some right side heart failure, and increased risk of atrial fibrillation. But the problem here is that if we don't fix that stenotic valve, that's super, super terrible and really bad, it's going to continue to get worse, and everything that we do is not going to really help them very much. So we need to determine which patients are the best candidates for a particular type of therapy in mitral stenosis. You know, there's a condition that's called percutaneous mitral balloon commissurotomy. All it is we take like a catheter, we thread it through a vessel here and get it into the heart. And then what we do is we take this actual catheter and we have a balloon that we can inflate once it's near the area of the mitral valve, near that stenotic valve. And you can inflate the balloon to basically stretch open that mitral valve. and balloon it open and open up that mitral valve orifice. If we open up the orifice, you can allow for more blood to move through that area. And again, that's going to help the overall situation. What kind of patients is this indicated for? There's two particular indications. One, if the patient is asymptomatic, right? So they have no symptoms, but their mitral valve surface area, the area, is less than 1 centimeter squared. Remember I told you that was very, very bad? That was severe mitral stenosis. In these patients, they likely will need that balloon commissurotomy because they're not going to get much better just managing their heart failure symptoms. It's going to continue to progressively get worse. The other thing is if they're symptomatic, then you can be a little bit less intense with the mitral valve area. And particularly if their mitral valve surface area is less than 1.5 centimeters squared. These are indications to do a percutaneous mitral balloon commissurotomy. What would be a reason we would not want to do a percutaneous mitral balloon commissurotomy? It would be a contraindication or not a desirable effect if the patient has heavy amounts of calcifications. So if they have heavy amounts of calcifications on the mitral valve, it's unlikely that you're going to gain any pliability in that valve. And so in these situations, it might be better to go for the valve replacement. So when you have a patient with mitral stenosis, percutaneous mitral balloon commissurotomy is the preferred treatment in these two scenarios. But if there's heavy calcifications, or they fail this treatment, they get it and it doesn't really help them, they may need a valve replacement. So in this situation, there's two types of valves that we can actually utilize. We can utilize a mechanical valve and replace that actual damaged mitral valve with this one, or we can use a bioprosthetic valve. And what is the concerns with these? Well, again, with mechanical valves, they have a high risk of thrombus. High risk of thrombus. So they'll need anticoagulation forever, for the rest of their life, okay? So for this patient, they're at high risk of bleeding. So the preferred patient to actually do this on is those who are young and those that are on anticoagulation already, or they have a low bleeding risk. So they're on anticoagulation or they have a low bleeding risk. That's the patient who would be better benefited to get this mechanical heart valve. Again, it's important to remember that the mechanical heart valve, it's going to last a lifetime. So for these patients, you want them to be younger so that they have the actual worth of getting that valve, that mechanical valve. But again, it preferably would be less beneficial in patients who are older because again, it's a long-term valve. You'd rather have this particularly on the younger patients, and you have a high risk of bleeding because your anticoagulation needs are absolutely necessary. So you want to go with patients who are not only older, younger, but also lower bleeding risk and maybe on anticoagulation already. Bioprosthetics are less thrombotic, so they don't require lifelong anticoagulation. They have a low thrombogenic risk. So you may only need anticoagulation short term, sometimes just 3 months. But the thing for this one is it doesn't last very long. It only maybe gives you about 10 years. So because of that, we prefer this for the older patients. We also prefer this one if they have a high bleeding risk. So if they have a high bleeding risk, this actually is kind of the better go for type of one. And then the last thing is it also is at high risk of infective endocarditis. So you can actually get infective endocarditis of the bioprosthetic valve more with these bioprosthetic valves than you would get with the mechanical heart valves. And so that's another particular thing to be thinking about. Either way, valve replacements, when would I get it? I would get it for two particular reasons. One is I would go to the valve replacement for mitral stenosis if they have a contraindication, they have heavy calcifications, or the percutaneous mitral balloon commissurotomy failed. If that happened in these two scenarios, then I would do the valve replacement, okay? So that's mitral stenosis. We treat them with the above things, heart failure, atrial fibrillation. They're higher risk though than mitral regurg. And then if they have these two particular reasons, they get the commissurotomy. If they have heavy calcifications or they fail the commissurotomy, they get the valve replacement. Which one they pick is based upon these things we just talked about. Now let's talk about mitral regurg. All right, so when we talk about treating a patient with mitral regurgitation, remember acute mitral regurg is a little bit more severe, pretty scary situation that can happen, right? And again, what were the two scenarios that I want you guys to remember? Infective endocarditis and MI, so post-MI. In these two situations, you can develop a very severe acute mitral regurg that they can become hemodynamically unstable. Remember what I say in these situations. You're having all of this blood backflow right into the left atrium and then eventually going back into the left ventricle. The left ventricle is getting overloaded. It's getting overloaded and it's flooding back into the left atria, back into the pulmonary circulation. This is causing intense pulmonary edema. How do we treat the pulmonary edema in these patients? Well, one of the things that we can do is we can actually put them on something called BiPAP. So bi-level positive airway pressure, because that helps to push some of that actual edema out of the interstitial spaces. The second thing that we consider is things like diuretics. So giving things like furosemide to pull some of the fluid out of those interstitial spaces as well. The second thing that's also an issue, so one of the problems that we can see in patients with acute mitral regurg is significant pulmonary edema where it can cause hypoxemia. So treat them with these two situations here. The other situation is, again, they're having so much blood that's accumulating here, and every time they contract to push blood out into the aorta and into the systemic circulation, every time they pump blood out, they push a lot back into the left atrium. So their stroke volume is dropping and they're getting hypotensive. So the other particular issue here is they can be significantly hypotensive to the point where they can be in full-blown cardiogenic shock. And patients who are extremely hypotensive at the verge are in cardiogenic shock, the things that we would like to do for them is get this ventricle to squeeze as much as it possibly can. So I got to squeeze the ventricles. So we might use things like positive inotropes. These could be things like dobutamine, epinephrine. Actually, less likely epinephrine, just because we'll talk about why it squeezes down on the actual vessels here, and that might actually potentially reduce your stroke volume. So particularly, we only want the inotropes, not as many of the pressors. So inotropes, particularly like dobutamine or milrinone. The other thing that we want to do here is not just get the actual heart to squeeze harder to push more blood out, but we should actually try to make it easier for the blood to go from the left ventricle into the aorta. How do I do that? Well, I'm making it squeeze harder, but what if I make it squeeze harder and I make the pressure in the aorta lower so that it's less afterload? What could I do? I could actually give reducing afterload reducers. And if I want to reduce someone's afterload, what are the drugs I can give them? I can give them nitroprusside. I can give them hydralazine. I can give them nifedipine. I can give them a bunch of different things that can help to dilate those vessels, ACE inhibitors, ARBs, a lot of those drugs that can relax the actual vessels, particularly the aortic vessels, and drop down the actual pressure. The afterload will reduce and I'll be able to push more blood out of the left ventricle and into the aorta, and that'll increase my cardiac output and increase my blood pressure. So those are things that you may do. The other thing is, if these things fail, sometimes what we may do until we can get this patient to surgery is we may do something called an intra-aortic balloon pump. And it's a thing that inflates during diastole so that we fill the heart with blood well and get coronary filling, and then during systole it relaxes and it gives a good way of being able to kind of stabilize the patient until they can get to surgery. So this may be something to consider as well. But these are the two therapies that we'll do in the acute mitral regurg. And then once we've gotten these things stabilized, they need to get a valve replacement ASAP. Okay, that's their end goal. Until we replace that valve, they are at potential risk of going into complete cardiogenic shock and dying. It's the other flavor of this disease, chronic mitral regurg, that we have to be thinking about. So in chronic mitral regurg, in these patients, they're not completely pulmonary edema, hypoxemic. They're not hypotensive at the verge of cardiogenic shock. Remember I told you they're dilating? They're dilating. And if they're dilating, they're accommodating that higher volume. They're having less pulmonary edema, less hypotension. They're not going to be looking like this. They're relatively sometimes asymptomatic. So it's those chronic ones that we also have to be thinking about. So if they have chronic mitral regurg, what do I do? I'm treating their heart failure. I'm treating their atrial fibrillation, yes. But when do I go to replace the valve? At what point in time? The indications of when a patient with chronic mitral regurgitation will get a valve replacement, there's a couple reasons. One, is the actual left ventricular in systolic diameter. It's right here actually, that's perfect. If the left ventricular in systolic diameter is getting really, really big, because the ventricles are having to accommodate large amounts of volume. That means that it's getting severe to the point where it's greater than or equal to 40 millimeters. That is an indication for a valve replacement. So one particular reason is their left ventricular end systolic diameter is greater than or equal to 40 millimeters. Second reason, they have any type of secondary mitral regurgitation, any of them, whether it's dilated cardiomyopathy, whether it's some type of aortic regurgitation, whether it's systolic heart failure of other particular reasons, regardless, they have secondary mitral regurgitation and they have failed medical therapy. What is the medical therapy? Heart failure treatments, ACE inhibitors, beta blockers, sodium, fluid restriction, diuretics, adding on aldosterone antagonists, digoxin, all of those things. They've tried all of it and it's not working. And they're failing to be able to respond to that. Then they get a valve replacement. What's the last particular indication? Remember I told you that in patients who have mitral regurgitation, their stroke volumes are crazy high because they have such a large preload. And they'll continue to keep slamming blood out of their heart. Their ejection fractions tend to be hyperdynamic. If at any point it drops less than 60%, they are now having very bad left ventricular dysfunction. And we say that at any point, regardless if they have symptoms or not, if their left ventricular ejection fraction is between 30 to 60%, anything less than 60% really, this is, again, regardless of symptoms, so it could be plus or minus symptoms, they get a valve replacement. These are the three indications in a chronic mitral regurgitation that would get a valve replacement. One, they're super dilated ventricles. Second, they have secondary mitral regurg or any kind of really thing where they're failing medical therapy, that's a good enough reason. And third, their ejection fraction is no longer hyperdynamic. They have left ventricular dysfunction regardless of their symptoms. Boom, they get the valve replacement. Now that we know all of these things, we have a very good understanding of mitral valve disease. I hope you do. I hope you understand and just completely got this down pat now. Ninjas, if you did, I'm so happy and I love you. I thank you. And as always, until next time.